Hello, everybody. Here we are. This is chapter 58, special skin and wound care. So buckle up. This is a lot of information. Okay. So skin, that is your protection. Okay. When skin integrity is lost, that is an opening for pathogens to get in. What is a wound? A wound is any abnormal opening or break in the skin. And as nurses, we're responsible for inspecting the skin from head to toe, looking for signs of skin breakdown and reporting them immediately. Okay. Wounds are physical injuries that can be because of trauma, incidental, accidental, or self-inflicted, or ulceration. So here's some examples of different types of wounds. An abrasion. An example of that would be a road rash, right? Abrasion. A puncture wound. A laceration is a cut, surgical incision. And then there are different types of ulcerations. Stasis ulcers, diabetic ulcers, pressure ulcers, okay? So as the nurse, you're supposed to be inspecting bony prominences. In other words, if a patient is not moving, if they're immobile, if there's pressure on some of the bony prominences like the back of the head, the back of the ears, think about O2 tubing, the heels, the coccyx, the scapulae, and elbows. Those are the most common. So you want to evaluate them very, very frequently, at least daily. And what you're looking for is hyperemia, non-blanchable hyperemia. In other words, when you press on an area, let's say the coccyx is red. When you press on that reddened area, it should blanch. It should turn white, and then the color should come back. If it does not blanch, that's hyperemia, and that's the same as a stage 1 pressure ulcer. And we're going to go through the staging so that you understand the wounds, okay? Drainage. Sometimes wounds will drain. The word exudate means drainage that contains dead white blood cells and cellular debris. It's like pus, right? But there are different types of drainage other than that. Serous drainage is thin, watery, can be clear, can be a pale, pale yellow, considered normal drainage. Okay. If you have a wound or an incision, you're going to have some serous drainage. Okay. That is your body trying to help that wound heal. Then there's serosanguinous drainage. Serous drainage, but tinged with blood. Also can be normal. Sanguinous, and that's from the Latin word sanguine, which is blood. Sanguinous drainage is just bloody drainage. Purulent drainage, that's usually a sign of infection. That's the same as saying pus, okay? Viscous means that it's thick. Copious amounts means there's a whole lot of it, okay? The color can be green, can be white, can be clear, can be yellow, can be bloody, right? If it has a bad odor, malodorous, that's usually a sign of infection. And copious amounts, if they're draining a whole lot, that can be weighed to determine the approximate amount of drainage. So if you're doing I&Os on someone, believe it or not, output would be weighing those drains or weighing those dressings to see how much drainage there is. So you know the weight of the dressing before, when it's dry, and then you weigh the dressing when it's removed from the patient, subtract, and you have an approximate amount of drainage, okay? You know, they use that in the operating room to determine estimated blood loss, EBL. Okay, measuring wounds. When you're measuring wounds, you always measure the length at the longest point, and you can look at this picture. Longest point from here to here. Width at the widest, here to here, and depth at the deepest. This one doesn't have real much depth to it, okay? So we just have length times width. You're always going to check for tunneling or undermining with a cotton-tipped applicator. So here you have two pretty standard ways to measure wounds. This little nifty thing is a clear plastic thing that you can put right over the wound, and it will give you measurements, or you can use a little disposable ruler, okay? And again, wound area approximations, you're looking at the length times the width. That gives you the estimated area of the wound, okay? Here's some examples of tunneling and undermining. With tunneling, you see it looks like two wounds, but when they put the cotton-tipped applicator in, look, it comes out there. It's really one big wound that's tunneled, okay? And then undermining, when you take your cotton-tipped applicator and place it under the edges of the wound, it shouldn't disappear. When it does like this, you can't even see the cotton tip. That's undermining. Okay. And you always document a wound as if it were a clock. So for this wound, you're looking at, this is the coccyx, there's the patient's spine. So this is 12 o'clock. This is 6 o'clock. This would be 3 and this would be 9. Okay. So here I would document undermining of so many centimeters at 12 o'clock. Okay. All right. Some other terms you should know. Macerated. Maceration happens when skin is in contact with moisture. Think about when you're in a tub for too long or in the pool or the ocean for too long. Your skin gets wrinkly. That's maceration. Excoriation is reddened, inflamed, right? Abrasions or erosions. It can be trauma, like road rash, right? Open wounds sometimes are excoriated. So just think about as excoriation. And excoriated skin can show signs of something called lichenification, which is thickening of the skin, or hyperpigmentation. The color can change if there's repeated trauma to that area. Other characteristics of wounds, wound edges can be rolled under, macerated, or calloused. If you look at these wounds, these edges are kind of rolled, okay? The peri-wound area should be intact, but it could be pink, erythematous. Look at this. See the red around the wound? That's erythema. It's a sign of infection. Okay. All these other fun words. Erythema is redness. Excoriation is kind of like road rash. Blistered. Ecchymotic, which is bruised. Denuded, which is eroded. Blistered is written twice. We don't need that. And macerated. And then the description of the wound bed. Is it granulated? Is it slough or is it necrotic? This wound bed is mostly granulated tissue. It's red. It's beefy. Good blood flow. This wound is covered in yellow slough. Lots and lots of slough. See all that yellow gunk in there? That's not purulent exudate. That's slough. So that needs to be debrided or removed in order for that wound to ever heal. And then right here, this little area that's black, that's necrosis. That tissue's dead. Okay, dead. That needs to be removed for that wound to heal. Okay, different types of wounds. There are pressure ulcers, diabetic neuropathic ulcers. You can have shearing of the skin if you don't move a patient right. Friction and shear is when if you drag them across with the sheet, you can actually give them like a road rash. Urine or stool incontinence or excessive perspiration can cause moisture-associated skin damage, MASD. Okay. And that's something that we're going to talk about in a minute. I'll show you even a picture of it. So if someone is sitting in urine for a long time, this is what can happen. Then you can have venous stasis ulcers or arterial ulcers. And then you can have things like burns, frostbite, right? Those types of things. Why does skin break down? Well, immobility is the number one reason, right, for skin breakdown. Inadequate nutrition, hydration. Make sure you know these reasons for breakdown. External moisture like incontinence or perspiration. Impaired mental status in that they cannot sense that they're wet and therefore they will lie in the wetness, right? Or heavy sedation or anesthesia, okay? And sensory loss, if they're in a coma or they're obtunded, then of course they can't feel if they're wet. There's incontinence-associated dermatitis. This is like just a reddened, irritated, almost like a rash that comes from the acidity of the urine, right? So it's just like a dermatitis, like a skin inflammation. Pressure injuries, pressure ulcers, they used to be called decubitus ulcers. They're over a bony prominence, right? Not usually, they are over bony prominences. Areas of the body where the bones kind of jut out. Venous stasis ulcers, which is a venous insufficiency wound. That is from bad venous return. So if the blood kind of sits in the lower extremities and can't get back up due to immobility, then what can happen is edema, and then they can wind up with breakdown, and that would be a venous stasis ulcer. Those are not staged like pressure ulcers, and they are not found on bony prominences. They're usually on the lateral or medial aspect of the lower extremities. Diabetic ulcers, usually find these on the feet, and that's from, diabetic neuropathy and lack of blood flow and breakdown. And then MASD, moisture-associated skin damage, which is kind of like the incontinence-associated dermatitis. They're very similar. If you look here, that's MASD. That's someone who has probably been sitting in a wet brief for a while. Okay, that's very sad. See how erythematous that is? Very angry looking. All right, question. The nurse should not massage any reddened pressure points or inspect wounds under fluorescent lights. Let me tell you, that is true. Never, 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 never massage any area on the skin that's discolored or a pressure point that's reddened, because this can accelerate the breakdown. And you should not look at wounds under fluorescent lights because they kind of change the tone of the skin color, right? Incandescent lights or LED lights are the best, okay? All right, let's go to pressure injuries, okay? They're the result of pressure, more than the skin and the tissue can take. They're found on bony prominences, and they are either staged 1, 2, 3, 4, or they can be unstageable. And then there's one more, suspected deep tissue injury. But when you look at these wounds, you see the heels, notorious, the coccyx and the buttocks. I mean, that's horrible, right? And there you have a heel. Okay. So we always, when we evaluate our patients for the first time, we evaluate them for their risk of developing pressure injuries at admission. And it's usually the Braden scale. Usually. Can be, there's another scale called the Norton scale, but I'm only going to talk about the Braden scale. And this is the Braden scale. It looks at their sensory perception, moisture, activity, mobility, nutrition, and friction and shear. So can they feel that they're wet? And all of these have 4 options except the last one. So you would choose a number, like if they're if they're in a coma, they would be a 1, right? Completely limited. Moist, are they always moist? Sometimes, occasionally, or rarely? Again, you can read these, you give them a score, and then you total the score up. And that predicts the risk, okay? Now, let's look specifically at pressure injuries, okay? So I'm going to show you stage 1. This is a stage 1. It's pressure-related alteration of intact skin. The skin is not open, and it's non-blanchable hyperemia, right? Superficial. It's reddened, okay? Stage 2, you have partial thickness loss. It's of just the dermis and epidermis, usually a little bit into the fascia. Stage 3 is full thickness loss, and it goes down deep into the subcutaneous tissue. Stage 4 is an anatomy lesson. Goes well beyond the subcu tissue to muscle and bone. Suspected deep tissue injury, it's kind of purpley looking and you don't know what lies beneath. And unstageable, similar. It's necrotic, so you don't know how deep it is. Okay? So here's a stage 2. See that blister? A blister is officially a stage 2. So even though the blister's covering it, what's under the blister would be open if the blister were to pop. This is a stage 2, loss of the epidermis and a little bit of drainage into the dermis. It's either a shallow crater or a blister. Here's a stage 3, gets down to the subcutaneous tissue. You may even see subcutaneous fat. Right? Stage 4, my God, extensive damage to the underlying structures, full thickness loss. You can see tendons, bones, muscles, anatomy lesson. It's horrible. Unstageable. It's usually a full thickness loss, but we don't know the depth because there's so much slough or eschar that we don't know how deep it is. So we can't really stage it. It's worrisome because if we debride it and remove this stuff, it could be very, very deep. And if they're a diabetic, it's not going to heal. And then suspected deep tissue injury. This is where you see purple or maroon intact skin or a blood blister. And again, we suspect it's deep, but we don't know. We don't know for sure, unless that thing opens up. And here you go again. Stage 1 is the non-blanchable hyperemia. Stage 2, now it's open. Stage 3, full thickness. Stage 4, full thickness to the muscle, bone, and tendons. Unstageable, too much necrosis. Deep tissue injury, we suspect. It's just like a bruised area or a blister. Okay? All right. Just know this, when a pressure injury heals, we never go backwards in stages. So if the patient had a stage 4 that is healing, it's always a stage 4. It never becomes a stage 3, 2, 1. No, it's a healed stage 4 or a healing stage 4. Okay. And how do we prevent these from happening? Remain alert for signs of pressure on bony prominences, right? Always check them. Turn and reposition every 2 hours minimally. Don't drag them across bed linens. Do not use donuts for them to sit on or egg crate foam for them to lie on. That causes more breakdown. Make sure that they are eating and drinking properly. Keep their skin clean and dry. And if necessary, you can order some things like an alternating pressure air mattress, which is a mattress overlay that actually changes pressure to kind of help move them when they're not moving. Okay? They're very nifty. Let's talk about how wounds heal. You have primary intention, secondary intention, and tertiary intention. Okay. The first one, primary intention. This is when the wound edges are approximated. It's a cut, right? Where you could take the wound edges, put them together and staple it or glue it or suture it. Okay. Healing by secondary intention. That takes place when the edges can't be approximated. In other words, it's an open wound and the wound needs to heal from the inside out. Okay. That's a slow healing one. Okay. And tertiary intention is a combination kind of both of the above. You can't suture it or staple it right away. You got to let it heal some and then you can suture it closed. This is something like a dehiscence of a wound. And that's another word that you need to know. Dehiscence. Example, dehiscence, which is a surgical wound that opens. Okay, so that's an example of tertiary intention. So if that wound opens, we may not be able to suture it right away, but we will at some point be able to suture it. So we need to let it heal a little bit first. Usually we'll pack it so that it doesn't close up without the inside healing first. Okay, and here's just another example of primary intention. You've got this wound where we can bring the edges together and suture it, right? Secondary, we got to leave it open. It's got to heal from the bottom up. Tertiary, well, maybe it's infected or it's dehisced. We have to let it heal for a while. And then once it gets smaller, we can suture it. That's the slowest. Okay. Here are some basic wound care products. These are abdominal or ABD pads. These are drain sponges. They're for trachs or peg tubes. These are 4x4s, non-sterile. 2x2s, non-sterile. Vaseline gauze and Xeroform. More types of products. They are gauze that are embedded with basically Vaseline or Vaseline and a bacteriostatic agent called bismuth tribomorphinate, which protects it, antimicrobial. We want to keep the wound moist. That's when we use Vaseline gauze or Xeroform, and they don't stick to the wound bed. Then there are steri strips and butterfly strips. These are used for skin tears or incisions where you can approximate the edges of the wound and they work almost like a suture, but they stick on and you allow these to fall off on their own. Okay. They don't get removed. Then there are alginates. They're usually used for wounds that are really draining heavy. Calcium alginate or silver alginate because they're antimicrobial. Hydrocolloid dressings like a Duoderm used for pressure ulcers. Hydrogel, which is a gel that's kind of like a polymer and it's got high water content. So it looks to the body almost like our own living tissue. So moist wound environment helps, especially pressure ulcers, helps them heal. Okay, and here are some examples of the dressings. This is a Duoderm. We use those a lot for pressure ulcers. Aquacel, which is a calcium alginate. Here we see a packing of a wound. This is Xeroform petrolatum dressing. That's that embedded gauze that's a Vaseline, but bacteriostatic Vaseline. And here we have a foam dressing, which is also a type of hydrocolloid, keeps it moist. Why do we do wound care? To keep it clean, to remove dead tissue sometimes, to prevent or manage infection, to make sure we're filling empty spaces so that the wound heals properly from the inside out, keeping it moist, reducing pain, and protecting not only the wound, but the skin around it, the peri-wound skin. It's important. So different types of dressings, they protect wounds from contamination and further damage, or They collect the wound exudate. Sometimes they assist with debriding the wound or getting dead tissue out, right? Dry dressings can be sterile or non-sterile. Packing, like I said, to keep the wound open so it can heal from the inside out. Debridement, the removal of dead tissue. There are 3 basic types of debridement. Okay? The first type is mechanical debridement, which is when we put a wet to dry dressing on. That means we take gauze, we saturate it with saline, we squeeze most of the saline out so it's wet but not dripping wet, put it on the wound, and then put a dry dressing over it. Change it the next day. When we change it the next day, when we pull that dressing off, it'll dry it up and it will pull off some of the dead tissue. That is mechanical debridement. Also, wound irrigation can debride. So when we forcefully irrigate a wound with saline, that will sometimes get some of the slough out. Then there's surgical debridement. We have to bring them into the operating room and cut the necrotic tissue away. And then there's enzymatic debridement, Santal. That's a collagenase debriding ointment. So we put it on the wound and it will chemically debride or eat away at the dead tissue or the slough. Okay? It does not damage good skin though. So then sometimes we need a drain. If a wound is deep and there's a lot of drainage, we will put a drain in sometimes in order to help the wound heal faster and prevent infection. This is a Penrose drain. It looks like a ZD, okay? It looks like a ZD, and it's got at the distal end a safety pin. It is an open dressing or open drain. What that means is the drainage just flows out. Usually we'll put an ABD pad under it to gather the drainage, okay? Helps direct the drainage away from the wound. Penrose, let me highlight that, make sure you know that. Penrose drain. And then other drainage systems, the Hemovac drain looks like this. The little skinny tube goes into the wound or the incisional site and is sutured in and drains out the bloody drainage or the fluid. Or a Jackson Pratt, which is what this is. This is a negative pressure closed drainage system where we squeeze that bulb, put the lid on, and slowly it draws the drainage out of the wound. You must always measure how much and what the color is of the drainage. Those are closed drainage systems. Then we have the wound vac. Here's what it looks like. There is foam that goes into the wound, fitted perfectly to the wound, and then a clear drape over it, and then this little circular doohickey with this tube that goes to the pump, and then covered by another clear plastic drape. And the vac suctions that wound at negative 75 millimeters of mercury, 23 out of 24 hours a day, and it's totally silent. When you have a good seal, when this dressing is done right, you should hear. If the dressing is not right, you will hear. For real, then you know you didn't get a good seal and you got to start over. Other equipment, wound irrigation systems, like a continuous wound irrigator, you're never going to see that. Manual wound irrigation, things that we do, right? We've talked about that. You can have sutures that are removable, so you have to go back and cut them out, or they dissolve on their own. You can have staples. You can have retention sutures or liquid bandage. That's that kind of crazy glue that holds an incision together. Okay. We'll go into retention sutures later on. I think it's too much for right now, but make sure you know the things that I've highlighted so far. Okay. This is the way we remove sutures or staples. You have a kit. A suture removal kit comes with scissors and little tweezers. They're sterile. Once you open it, you take the tweezer, pull the knot, and snip under the knot, and you'll pull the whole suture right out. Staples, there's a little staple remover thing, goes under the staple in the middle, squeeze it, and it pushes the sides of the staple up and pulls the staple out. Pretty nifty, huh? All right, last question. Is it true or false? For suture removal, the nurse should place sterile scissors and forceps, cut the suture with sterile forceps, then remove the suture by pulling straight up on the knot. Does that sound right? That's right. This way, we're pulling the whole suture out and not leaving anything in the skin. And plus, it doesn't hurt as much. Well, I hope you got all that. Until next time, see you later. That was Wound Care 101.